topic today is shoulder arthroplasty. My name is Jody Gutkin. I have been a physical therapist for over 27 years, so I've seen a lot of things change in our field, and it's been wonderful keeping up with it and doing research to stay current also. I hold a master's degree in education and have been involved in physical therapy education for many decades also. I look forward to speaking with you today on our topic of shoulder arthroplasty. What we're going to focus on as we look at this topic is this relatively new procedure of shoulder replacement. We will review the pathophysiology of the conditions that lead to the need for an individual to have a replacement. We'll spend a good amount of time looking at the actual surgical technique, the prosthetic components of the total shoulder as well as the reverse arthroplasty, and we'll spend some time looking at post-surgical management as well as rehabilitation outcomes. The idea behind this course is this is a relatively new procedure, so the research is emerging. As I was reading about it for myself, I thought that you all might find it interesting too to hear a little bit about the history and get a little deeper into the prosthetic components. The thought is that this will give you a good base of understanding, because when you have those patients in rehab, the protocols from the different physicians may vary. And as we work through this content, you're going to find that there are a lot of additional procedures that are often performed along with the shoulder replacement. And there are very specific reasons related to the complicated anatomy in this area why patients have so many precautions for so long during the healing process. So as we work through this, it's going to give you a good foundation to better understand those protocols and engage in conversations with the patient for education as well as the physician if you need to, in order to understand the rationale so you can appropriately progress your patients. We will be looking closely at the anatomy in the area. There are some pictures that are surgical and cadaver sections so that you can see the actual anatomy. So if you have kids that might be looking at your screen or you're in a public place, you might just want to think about where your screen is pointing. I'd just like to give that little disclaimer. In addition to what I already mentioned, we'll look at post-operative management, managing complications in the long as well as short term, and we will discuss the rehabilitation protocols. So you're going to follow the specific protocol for the physician that has referred the patient to you. We'll look at some commonalities in what the research is showing. Where I've pulled my information from for this presentation are a variety of research studies from both the United States as well as outside of the United States, and from different surgical guides that are out there for the physicians. And then I looked at many different protocols for a lot of the large facilities in the country to kind of compile some information and look for consistencies. So I look forward to discussing this topic with you. As with any course that you attend, when you go back to apply this in the clinic, you're going to do so in accordance with your federal, state, and professional regulations. You will notice that several of the slides throughout the presentation have this icon on it. It's gold that says "Consider this." That's to let you know that those particular slides are going to be helpful when you go to complete the post-test. Before we can talk about the different surgical procedures for the shoulder arthroplasty, we're just going to take a few minutes to review our basic shoulder anatomy. We know that the glenohumeral joint is part of our axial skeleton. Appendicular skeleton. It's going to connect to our axial skeleton through the shoulder complex. Articulations we have additionally at the sternum with the clavicle, the acromioclavicular, and then the scapulothoracic joint. That upper extremity is very important in order to allow us to perform all of our different functional tasks. When we look specifically at shoulder arthroplasty between 2000 and 2010, there was about a 6 to 13% increase every year in the number of individuals who were undergoing shoulder arthroplasty. So it's about at the point where there's over 55,000 individuals a year receiving this procedure, which sounds like a lot, but it's still in its infancy when we compare it to hip and knee replacements, where there's over 900,000 a year. So this procedure is still developing. Basic review of our shoulder musculature. We remember that rotator cuff with our sits muscles, our supraspinatus, infraspinatus, and teres minor are coming in to attach here onto that greater tuberosity. And then our subscapularis muscle sitting on the anterior surface of the scapula. This muscle, you may not think that much about it. It's one of the primary internal rotators of the shoulder. They actually have done a lot of research in it, and they found that the subscapularis muscle is actually a biphasic muscle. And when we look at shoulder arthroplasty, it plays a lot of critical roles, so you're going to hear me mention it a lot today. First off, it's going to reinforce this anterior portion, where I'm coloring it in blue here, of our shoulder joint capsule. And then they've also noticed in the research that this is a biphasic muscle. So it is going to participate in shoulder abduction with those upper fibers, and then the lower fibers are going to participate in shoulder adduction, in addition to allowing internal rotation. So it plays many different roles in the shoulder. When we look at our convex-concave rule, please do not have scary flashbacks to college, right? The first time when you're memorizing this, it always seems so complex. Now you probably don't even think about it. As a rule, you just know. But when we look at the concave surface of the glenoid fossa and then the convex surface of this humeral head, when the long bone rolls up, we need to have the head glide down. So the roll and glide are in opposite directions in those glenohumeral motions, and that's what allows for full range of motion without impingement. This is important to understand when we move forward and look at the different precautions for shoulder arthroplasty. So for example, if a patient is reaching back doing shoulder extension, the long bone is moving posteriorly, but this humeral head is actually gliding anteriorly. As we look at the movements that occur, in order for this large humeral head to stay articulated with this small glenoid fossa, the relationship here, this humeral head is about 3 times the size of the glenoid fossa. So as we're performing different movements of our shoulder, there's a combination of compressive forces that are going to be inwardly directed forces by the rotator cuff, as well as downward forces to prevent impingement. What they need to control are the shear, the movement of the joint surfaces against each other, but they also need to keep this humeral head articulated with the glenoid fossa. So what actually occurs is a combination of compressive and shear forces that work together to allow joint movement to occur. And that rotator cuff is very critical in that role for us to perform joint loading appropriately. If there's not the right balance of those compressive and shear forces, we have a subluxation risk. And that's in the natural shoulder as well as after surgery. The arthrokinematics that we're looking at of the shoulder, the rotator cuff is playing that critical role in order to stabilize that humeral head on the glenoid fossa. So when our deltoid functions to, let's say, abduct that shoulder, we need to avoid impingement under the subacromial space. So this rotator cuff is going to give a downwardly directed as well as internal force in order to stabilize the humeral head and allow for functional movement. The terminology that's utilized for this when you look at the research is called concavity compression. So this is important for that humeral head to stabilize in that glenoid fossa. As we mentioned, we're going to have that combination of compressive and shear forces that allow the gliding of the surfaces in order for full pain-free range of motion to occur. It's going to create an appropriate fulcrum for that humerus to move in the glenoid fossa for full range of motion. There have been some interesting studies that have actually looked at the amount of force that goes through the glenohumeral joint with different upper extremity motions. When we think of compressive loading, it's easy to see in the lower extremity when we're weight bearing through a joint. But when we look at the dynamics of the shoulder joint, the fact that we have that large humeral head balanced in that glenoid fossa, as we're lifting different loads, that's a large lever arm. So the compressive force at the joint has to be significant to avoid subluxation. So that rotator cuff, those periarticular structures are really working in order to stabilize that joint, but also to allow movement. So there was an interesting study in 2017 where they took 25 individuals and they had them perform 26 different functional tasks. And they used different optical analysis, computer tracking of their motions in order to see how much force, compressive and shear, was actually created across their joint. And what they found with low load activities, so things like just feeding, where the upper extremity is at a lower level, where the glenohumeral joint is not in too much abduction or flexion, there's about a 32% compressive force that's going through that joint. As we get into more hygiene type of activities where we're getting into higher range of shoulder abduction and flexion, the rotation changes, we're looking at more of a 39% compressive force. And then if we consider sit to stand when someone is pushing up with their upper extremities, they actually calculated there was 164% of the body weight of force that goes through that extremity. So it's not only the body weight, it's the forces the muscles have to exert in order to stabilize that joint during the activity. And this is very important to understand when we're rehabbing our patients with arthroplasty and they have limitations is when they can perform different functional tasks based on the healing that has occurred. It's really based in part on this idea that there is a lot of compressive and shear force, and we don't want to disrupt that healing. There are several different pathologies individuals will present with that can require them to undergo a shoulder arthroplasty. Our first category are our traumatic shoulder injuries. These are individuals who have sustained a proximal humerus fracture, where they have had some type of fall or trauma that has fractured that humeral head. Another category are individuals who have degenerative conditions. The majority of individuals currently who undergo shoulder arthroplasty, about 75% of the cases, are individuals who have primary osteoarthritis. And then another cohort are individuals with rotator cuff arthropathy. So they have a rotator cuff that is not repairable, and it necessitates them, in order to restore function, to undergo a shoulder arthroplasty. We're going to look at the pathomechanics of each of these. When an individual sustains a traumatic shoulder pathology where they have a complex fracture, if we look at this X-ray here, we're looking at that proximal humeral head and tuberosities. We can see, I'll draw some lines to show you where they are all fractured off here. Remember, those tuberosities are where that rotator cuff is attaching. So when the individual has a complex fracture like this, not only are they at risk of avascular necrosis, but the physician may have a concern if he can't realign the segments appropriately that the length-tension relationship may have changed, and the functionality of the rotator cuff may have changed, so it wouldn't allow a functional shoulder for tasks to be performed. So the individual may need a shoulder replacement in order to restore a functional upper extremity, as opposed to undergoing an ORIF. When we look at individuals who have osteoarthritis of the glenohumeral joint, looking at this scan on the right, we see that classic deterioration. I'll draw a line here. In this square is where the joint space should be, but what we're seeing are osteophyte formation, cartilage deterioration, bone sclerosis, and a wearing down of those joint surfaces that's creating significant pain for this individual and not allowing them to have functional movement of their upper extremity. So all of the different calcifications in the area and the inability of the surfaces to glide restricts range of motion for this patient. Conservative management may not have been successful, and they're at a point where shoulder arthroplasty may be beneficial to restore motion and decrease their pain. Looking at rheumatoid arthritis, this has a different mechanism. Rheumatoid arthritis is an autoimmune disease. What we see in those individuals is that chronic inflammation. I have a scan of a hand. I couldn't find a good one of the shoulder, but it demonstrates that we see that synovitis that occurs in individuals with rheumatoid arthritis. As the joint surfaces deteriorate, they have significant subluxation of those joints. And what they're finding related to the shoulder and individuals with rheumatoid arthritis, when they look at shoulder replacement, that destroyed uniformity of the joint surfaces limits function and glide, and it creates a significant amount of pain for individuals. What they find, because there is such deterioration, that there's not sufficient bone stock in order for them to implant the prosthetic components. So currently the research says, and this may change as we have more advances, that for individuals with rheumatoid arthritis, if they do undergo a shoulder arthroplasty, it's more to decrease their pain. It doesn't restore that much function for them. But by decreasing pain, it may have a significant positive impact on their quality of life. Individuals who have a rotator cuff tear, when we look at the rotator cuff, the supraspinatus is the most commonly torn, but individuals can have different tears of different segments of the rotator cuff. It may be partial, it may be complete, and there are different ways that these are graded if you're able to see the MRI results. We know that every patient with a rotator cuff tear doesn't present exactly the same. So what they find over time when an individual has a rotator cuff tear is that looking at the muscle tissue, so where if this individual has a tear of the supraspinatus, where they're unable to appropriately recruit all of these fibers of the supraspinatus, over time this muscle undergoes atrophy. And we know a lot of times this is a long-standing pathology. What they're finding on imaging is that as the muscle fibers atrophy and it creates more spaces in here, fat starts to infiltrate the area. So that makes the muscle even less functional. So in some cases, even if they were able to repair the tear, because of the now damage to the muscle itself, it may not really be functional to serve its roles. So when you look at the different scaling systems that are utilized, the Gaulier scale is one that's utilized. And if someone has a 3 to 4 on that and they have significant tearing, they tend to find that those are individuals that fall under that category where it's not a repairable tear, where it wouldn't lead to a functional outcome if they just had a rotator cuff repair. What happens over time with an individual who has a rotator cuff tear is they end up developing rotator cuff arthroplasty. And this is specific because of the dysfunction of the rotator cuff and its inability to stabilize that humeral head. We're looking at a scan on the bottom here. This is, I'll be honest, when I first look at this, it's an ultrasound image. I had to consult a colleague who is in sonography. So here, blue that I'm drawing on the bottom, that is the humeral head, and we can see that that white line above it is an irregular surface. There's some osteoarthritis setting in. And then right here below the arrow, what you're seeing is the actual tear inside the white. You see kind of black in there. That's the tear in the rotator cuff. So when they say an irreparable rotator cuff tear, that is a situation where it's not functional. The individual starts to develop osteoarthritis, and now it's termed rotator cuff arthroplasty, because beyond having the tear, now they have also osteoarthritis setting in of that joint. What happens with the rotator cuff deficiency and the way this actually occurs when we look at the kinematics, we said that normally we have on the left-hand side, the axis of rotation of the humeral head and the glenoid fossa. As our deltoids abduct, our rotator cuff functions to keep this humeral head stabilized, and it maintains a good joint space up here under the acromion. In someone who does not have a functioning rotator cuff, and I think this is important for us to envision as we're working with our patients with rotator cuff pathology, what's happening at the joint surfaces. So what happens here on the right image, if we look at this dot in the blue line, that is our center of rotation on the glenoid fossa, and here's our center of rotation in the humeral head. Well, what happens as those deltoids abduct, if you don't have a functioning rotator cuff to control that shear and compressive force, see how we lost our joint space up here under the acromion? It actually is going to allow translation, superior translation of that humeral head every time the patient tries to lift their arm. What happens over time, every time that individual continues to utilize their upper extremity for functional tasks, is actually a pseudo joint formation. So this scan is actually an individual. The red lines I'm drawing are the articulations that should be congruent of the humeral head and the glenoid fossa. We can see there's a significant superior translation of that humeral head. And what I'll do in the blue, just below this arrow, in where those arrows are, if you look, what tends to happen is they call it acetabularization of the undersurface of the acromion. Because you have the humeral head constantly articulating with it, it starts to wear away this undersurface of the acromion and create more like an acetabulum in the hip. And this is leading to the pain and deterioration and arthritis in this joint. They grade this on radiologic examination. They use either a Seebauer or a Hamada classification. The Seebauer is going to look at that articulation. Is the humeral head still articulating with the glenoid fossa? In this individual, the glenoid fossa is all the way down here and the humeral head is all the way up top. They're not articulating with each other. The Hamada classification, if you are able to see the reports, and this is even beneficial for any patient, for us to understand what's going on in that joint, we can see in this patient the fragmenting and fracturing of the acromion process because there is no longer a space. The humeral acromial interval has disappeared because of so much superior translation. So this patient, what they need is replacement in order to restore some functional movement for this extremity. The way we see this presenting clinically with the individual is every time that they attempt to move their upper extremity, when they have that rotator cuff that is not functioning to control the superior translation, we have that superior migration every time they move their upper extremity, and they actually present with what's called pseudo-paralysis. This means anytime they try to lift their arm over a certain degree where for them, they're at the point where that humeral head is now articulating with the acromion, they just can't lift anymore. It looks like they have a pseudoparalysis, like they can't move that arm, but that's not the case. The muscle may be intact, the deltoid, but they can't move because of the joint incongruency. And then what happens over time is it leads to significant arthritic changes and a non-functional extremity for that individual. They estimate that about 2% of the population over 80 years old present with a pseudoparalysis because the rotator cuff tends to deteriorate with age, and it leads to a deterioration in function of the upper extremity. Clinically, we'll go through some conservative management to attempt to rehabilitate individuals with an irreparable rotator cuff repair, but oftentimes they do end up needing a shoulder replacement in order to restore function. When we look at the shoulder replacement, the historical perspective is actually pretty interesting, so I'm going to share it briefly with you. The first shoulder replacement was actually in 1893 in France. That was back at the time where the individual had septic tuberculosis that went into his shoulder. He was a baker and he refused to have his extremity amputated because he was young, in his 20s. So there was a replacement done of the shoulder. This is an actual picture of the prosthetic components. They used a hard rubber head. They used horse hairs in order to reattach the different tendons. And they were actually able to restore function of this individual and decrease their pain. Fast forward to the 1950s, Dr. Neer at Columbia Presbyterian in New York, he was working with individuals who had proximal humeral fractures, and he just wasn't satisfied with the outcomes of these individuals when there was just head resection done. So he developed the components for a shoulder arthroplasty. His patients were able to go back to some farming and carpentry activities. He continued into the 1970s to perfect his components and try to provide a more functional upper extremity, but what was found is that the components would loosen in some patients, and they weren't really sure why. So they started to continue to look at the design, and in the late 1980s, 1987, Graham developed the reverse design, specifically to target those shortcomings of loosening of the prosthetic components. And then finally, in 2004, the reverse shoulder arthroplasty was approved here in the United States. So as I mentioned, it's really still in its infancy here in terms of the research. The goal of surgery for individuals is looking at restoring function, decreasing pain for the individual. When we look at the different types of shoulder replacement, there are several different procedures that can be performed: a hemiarthroplasty, the anatomic total shoulder replacement, and then the reverse shoulder arthroplasty, all with different modular components that we're going to take a look at. Hemiarthroplasty is just as the name says, hemi meaning half. So in individuals with a hemiarthroplasty, we can see in the scan here that they are going to replace this humeral head component with a stem that goes down into the shaft. The individual's glenoid fossa is still intact, so that humeral head is going to articulate with the intact glenoid fossa. They say that for the individuals that undergo this procedure, they may have some pain that results over time because you do have that intact cartilage in the glenoid fossa articulating with the artificial head. So that pain relief tends to be a little, they say, unpredictable for those individuals. The reason they might choose to utilize this procedure is when someone has a very severe humeral head fracture where there was that turning and twisting and fracturing off of the tuberosities, or a concern for avascular necrosis. So they might go in and try to do a humeral head hemiarthroplasty. In individuals who have a pathologic fracture, maybe due to metastases, the individual may be a candidate for the hemiarthroplasty. It's a more conservative procedure. If the individual is younger, they might choose to do this so that down the road they do have options of the more involved shoulder arthroplasty. So they might go with that conservative procedure at first. When we look at individuals who have rotator cuff arthropathy, there is a specific prosthetic which is called the cuff tear arthroplasty. If you look at this component in the bottom left, you see how it has this enlarged cap at the top and then it comes around? So in the top right image, if you envision where that would articulate, that large cap articulates with this undersurface of the acromion and then the glenoid fossa. So it's accommodating for that fact that acetabularization of the undersurface of the acromion. So they know that they need to fill that space and allow movement there more functionally. So the prosthetic component is going to fill that space for the individual. This isn't done as commonly. I just want you to understand what that procedure is. What you're going to see more commonly is either the total shoulder arthroplasty or the reverse shoulder arthroplasty. I will tell you that there are so many different names that are utilized, but the consistencies that we tend to see in the research are the terminology anatomic total shoulder arthroplasty, where the patient has an intact rotator cuff, and then the reverse shoulder arthroplasty, where they do not have an intact rotator cuff. We're going to take a closer look at each of these. First, anatomic total shoulder arthroplasty. Generally speaking, if it's said in the research, or double check with the physicians that you're working with that are referring to you, if the term is just that the patient underwent a total shoulder arthroplasty, this first procedure that we're discussing now is likely the one that they underwent. It's called a near prosthesis that's utilized if you look at the actual components, maybe in the op report. What's done in this procedure is it's kind of like your typical total hip replacement. They have removed and resected out the humeral head. They will remount the glenoid fossa. There's a stem that goes down into the medullary canal of the humerus, and then that's going to create your new joint articulation. This is going to be utilized more commonly in patients with osteoarthritis, where they have potential risk of avascular necrosis. They want to remove those bony structures that have deteriorated and replace them to allow for function. It's a metal alloy that's utilized that is implanted down into the shaft of the humerus, and then there would be an articulation also with that glenoid fossa. It is just replicating the normal anatomy of the shoulder joint. The actual components that are utilized for that humeral implant, when we look at them, it's a stemmed design that goes down into the medullary canal. If we remember that these are patients that have arthritis already, their bone quality may vary. So what they're moving towards in the components is to go with a shorter stem, and some are even stemless. It just has like a little tiny stem and almost a cap that just goes over that humeral head, because the concern is that as they ream down more into and hammer down more into that medullary canal of the humerus, which isn't very thick, if it's not good quality, there's a risk of fracturing, and now the patient has another potential pathology that needs to be managed. Also, if they go shorter initially, then they have the option, if the patient needs a revision down the road, they have good medullary canal that they can utilize to go deeper for stability. How they fixate this, it's either going to be press fit or cemented. When they do the cemented, this is going to be your typical cement that they place in the canal in order to allow greater stability. Or in the image here, we can see this kind of trabecular surface lattice work on the prosthetic component that they press in, and then the natural bone will grow into place to stabilize. I found a 2017 study. It was a pretty large cohort of patients that they followed from the 1970s to 2012, comparing for the total shoulder, the cemented versus the pressed fit. And they really found that in both of those, at 20 years, there was still in the high 90% of stability and survival of the components. So the physicians are making good choices. Looking at the glenoid component, when they need to fixate that base plate in for articulation, it's a little bit different than they consider for the hip. Additionally, they would be adding just a metal-backed component, but they found with all of the movement of the upper extremity that sometimes just the metal component with the screws going in created instability and it would loosen over time. Also, if you look at this surface area, there isn't much distance for them to drill the screws into because we have a lot of neurovasculature in that area. So what they've moved towards is actually an all polyethylene design. So it's all plastic design. And in order to stabilize it, what they put on the back built in, it kind of reminds you of like a drywall anchor at the image up here where it has those little kind of ridges in it. So it's going to go in and kind of create some traction in there in order to create stability. So they have different channels and ridges, and they're just using a polyethylene kind of cap over that glenoid fossa in order to stabilize. So it's able to absorb all those compressive and shear forces without as much of a risk of loosening. The total shoulder component is considered an unconstrained design. By unconstrained, this means it replicates the normal shoulder anatomy. In doing so, the patient needs to have an intact rotator cuff in order to control those compressive and shear forces, that superior translation. So it's very important that these patients have an intact rotator cuff in order for this procedure to be successful. If the physician has a patient where the rotator cuff is not intact, that's going to be when he's going to opt more likely for the reverse shoulder arthroplasty. This is the grommet prosthesis. And again, these are patients where they do not have an intact rotator cuff. Maybe they have a very complex proximal humerus fracture where the physician just cannot regain alignment to have a functional rotator cuff, even though there may be muscle integrity if he can't restore the anatomical alignment. Or it may be a progression from either a shoulder arthroplasty or a hemi where they're going to go with this reverse procedure. The reverse shoulder arthroplasty is just that. What they literally do is flip the components. So in this image in the right, what we see on the humeral side is the components going into the shaft of the humerus. And then on top of that, we have our polyethylene articulation, our concavity. So our concavity now becomes on the humeral head, and then the convexity becomes on the glenoid fossa. So they literally just flip the articulation. So they call the glenosphere is now on the glenoid fossa, and the concave portion is now on the humerus, which is amazing to think that someone even considered that this is an option to perform. When we look at fixation of that humeral component, they're going to again have the options of either a cemented or an uncemented. The research says that there is in the cemented design a risk of nerve injury or potential infection or blood clots. And in the uncemented design, they did have some concerns that there was more shifting of the stem. So each kind of have their ups and downs. And again, this was only approved in the United States about 15 years ago, so there's still, the research is evolving. What they tend to find is that the outcomes for both seem to be similar, whether they're cemented or uncemented. Some of the research said that if it's more osteoarthritis and a fracture, they tend to be leaning more towards the cemented design to allow for a little additional extra stability. at the specific design of the reverse shoulder arthroplasty, it's considered a constrained, probably more accurate to call it a semi-constrained design based on some of the research. We said that the individual who undergoes the reverse shoulder arthroplasty is typically the patient who does not have this intact rotator cuff to stabilize that humeral head on the glenoid fossa. So the design component of reversing the convexity and the concavity is to allow this joint to remain stable without a rotator cuff that's functioning to control its stability. So it gets a little bit into, arthrokinematics, but mechanical design. And it comes down to the fact that what they're doing is they change the axis of rotation of the joint so that when the patient moves, just the alignment of the prosthetic components maintains this subacromial space, so that we don't have the prosthetic component articulating with the undersurface of the acromion, creating impingement, not allowing range of motion. Taking a closer look at this, I am not an artist, so these are my attempts at drawing to explain these concepts. I think despite my poor artwork, you're going to get it. So here we go. So this componentry has what's called a fixed fulcrum. So we said that the structural integrity of the prosthetic components are what's going to allow an appropriate articulation between the joint surfaces to avoid malalignment and allow for a functional extremity. So what normally happens, this image on the left, we have our center of rotation of our humeral head that aligns with the center of rotation of the glenoid fossa. So when the deltoid contracts for abduction or flexion, our components, our center of axis remains aligned and we maintain a good subacromial space. That's normal. So what happens when you don't have the rotator cuff to do that is they change the design. So on the right-hand image here, if you were to look at where the center of rotation is of this componentry, so if we look at the center alignment of the glenoid component, which is the convexity, and then the center alignment of the humeral component, which is the concavity, the center of rotation is actually moved medial and inferior. In doing that, see how it naturally creates this larger subacromial space? By doing that, creating that larger subacromial space and mechanically kind of changing the alignment where this is moved down, think of this deltoid here, that length tension relationship. If the humerus is moved more distally, it actually elongates that deltoid a little more, so it has a better length tension relationship. So now that deltoid becomes a lot more functional at abducting and flexing that shoulder. It actually allows some of those fibers to be better at internal and external rotation to compensate for that rotator cuff that doesn't exist in this patient. So that's why they flip this design, so they can move the axis, let that deltoid function better, and the componentry makes up for the fact that the patient doesn't have a functioning rotator cuff. I think it's amazing. Because of this, there are certain contraindications for patients who would not be candidates if they have axillary nerve damage. We know that that alters the innervation to the deltoid, which now that deltoid is so critical for functioning of that upper extremity post-operatively. And it's important, if you are seeing these patients preoperatively and you're maybe not sure what to work on with them, you might want to consider really strengthening up that deltoid group for all of its motions, particularly in that transverse plane for rotation, because it's going to assume more of a role in that aspect. Also consider patients that are contraindicated are ones that do not have a good bone stock. So if they don't have good density to their bone, there may not be enough space to allow for the implantation of that large glenosphere on the glenoid fossa. For both parts, for the total shoulder arthroplasty as well as the reverse, as I read the different guides and looked at the different surgical considerations, the bony architecture is very complex in that area. When we look at this, to orient you, we're looking at, I'll draw a circle, head of the humerus, the biceps tendon here. We have our joint capsule. This is a very tight area. There's lots of angulation to the different structures, so it's really important that just a small difference in any of the orientation of the different structures when they're replicating the anatomy with the prosthetic components can have a significant impact on function, but also small shifts change the length tension relationship of all the muscles that can alter the outcome. So the physician has quite a job when he's working in there. One angulation that's important for them to look at is the neck shaft angle. Generally speaking, this neck shaft angle, so if we look at the shaft of the humerus and then that neck angle, generally speaking, this is about 135 degrees. That's what they're attempting to replicate when they implant the prosthetic components. What happens is if they change that angle too much, where they shift it and open it up too far, and this happens a little more with the reverse arthroplasty, when they implant that concave portion, if they open it up too much, where they put it maybe a little too much vertical, if they open that angle up to more like 155 degrees, what they found in the research is that articulation now, that stability of the joint that should be created by the prosthetic components becomes compromised, and those patients tend to present with more shoulder instability and potential risk of subluxation. So like with any surgical procedure, if the patient is going through rehab and something doesn't seem right, there's instability or their range isn't appropriate, that would be something to feed back to the physician. Not that they did something wrong, but like with any surgical procedure, something just might be slightly off that the physician needs to take a look at. The male-female anatomy they're finding makes a difference here. They actually did a study where they looked at 205 radiographs and they did computer analysis and mathematical calculations looking at all of these different articular structures and orientations. And they found that ethnicity didn't make a difference in the components, but gender seems to. So I think what we're going to start seeing maybe moving forward are different gender-specific components. They actually found that the curves and the angulations are slightly different. When we consider what the physician is looking at in terms of when I say a small variation has a significant impact, the tip of a crayon, if we look at how wide the surface of the tip of a crayon is, that's about 2 millimeters. And that brand new eraser, that you always had to have in test day before computer testing, is about 5 millimeters. Well, somewhere in between there is about 4. What they find is if there's a 4 to 5 millimeter discrepancy in the joint surfaces when they add that prosthetic component or the angulations, it can have a significant impact in function. So the research is really looking at developing components that are modular to get the appropriate alignments. This is all very important because tensioning of that deltoid is very important in order to allow functioning of the upper extremity, particularly with that reverse arthroplasty, that if they tension the deltoid too much, meaning that the humeral head maybe is sitting a little bit too high or something shifts it where that deltoid, tension it too much would be where there's too much tension. It's a little too tight in there, it's going to pull up and fracture that acromion, versus if it's a little too loose in there, it's going to allow instability of the joint. So it's important that the physician is, he's going to spend a lot of time looking at restoring those length tension relationships. When they look at fixing the different components, as we mentioned, they're going to use different locking screws in order to place potentially that glenosphere if they did a reverse, and if they did a total shoulder, that polyethylene component, they're going more towards just polyethylene kind of grounding type of screws in there. What they're finding in fitting the humeral component is, rather than using bone chips that tend to be a little rigid, that when they take off the humeral head that has deteriorated, they're kind of scooping out the medullary components and they're using that to pack in to allow better fixation. And I just find all these things interesting. If you do have the opportunity to see a surgery or read the op report, it just gives us a better understanding to think about as we're doing range of motion and activities with the patient, what's actually happening down at the bony level. As we consider the different procedures, there are times where over the life of the prosthesis in the individual's life, they may have failure of the prosthetic components. It can be early on, it can be later for a lot of different reasons. The progression that seems to be indicated at the current time, if someone starts with a hemiarthroplasty more conservatively, what happens over time, that glenoid fossa may start to deteriorate, so they may go to a total shoulder if they still have that intact rotator cuff. If that fails, then they have that opportunity to take that patient to the reverse shoulder arthroplasty. What they're finding in some individuals is that as they are getting older and the rotator cuff naturally becomes weaker with age, that they may need to shift to that reverse arthroplasty. The surgical approach that the physician utilizes when he goes in to gain access to the anatomical region, there are a couple of different options of how the surgery can be performed. Either way, what they're going to place the patient in is called the beach chair position. Hopefully I'm keeping your attention and you wouldn't rather be doing this than listening, although who wouldn't rather be doing that? Beach chair position is where the head is going to be elevated about 30 to 60 degrees, and they'll position the patient, then they'll put a roll posteriorly because they really need to have good alignment of the scapula on the thoracic cavity and then that orientation of the humerus to the scapula, because when they're tensioning the muscles, they need to have normal anatomical alignment. They need to balance that with actually accessing the area for the surgery. So they tend to put a little bump behind there. The two different surgical approaches they'll use is either deltopectoral, which is more common, or the anterior superior approach. For the deltopectoral approach, when they go in, this is less traumatic to the muscles in the region. On the right-hand image here, we can see that the pectoralis major muscle coming in and off the clavicle, and then the anterior deltoid coming in off the clavicle. We tend to have a natural intramuscular space there that can be divided to allow access. So on our patient on the left-hand side, what you're going to see is the surgical incision is usually going to start kind of just above the coracoid process, and then it's going to come diagonally down towards that deltoid tuberosity on the humerus, and then they're able to just kind of spread open the musculature so it's less traumatic. They didn't have to cut anything, and then after the procedure is done, they can just let those muscles retract back by going through that natural junction. Once they get open into that area, to orient you on this image, let's see, so here we have cut away on the right-hand side, that's the deltoid. So in this image, they just took that out so we can see. It would be retracted out during an actual surgical procedure. What we see here as we look at the anatomy where the surgeon is attempting to do their replacement is coming in here. I'll draw a blue line kind of on the left. This is our axillary nerve coming in. We can see how close that is. On the other side here is where we're seeing this humeral head, where the physician is doing surgery. So they have to really be cautious of that axillary nerve going to the deltoids in that area to not create damage to it. There's also our circumflex vasculature coming right here that goes around that humeral proximal shaft in the area that the physician has to be cautious of. And then in this area, we see our brachial plexus coming down. So there's a lot of potential risk here of transient nerve damage for the patient during the surgical procedure that the physician needs to be cautious of. When we look at the structure in the area, in addition to what we just mentioned, once they're down at this level of the rotator cuff, the subscapularis muscle is coming around and it actually reinforces that anterior joint capsule as it goes to insert on the lesser tuberosity. So it comes across that anterior shoulder. They need to get that out of the way in order to get down into the joint space to complete the arthroplasty. Even if a patient does have rotator cuff involvement, the subscapularis isn't as commonly torn, so it might still be intact. The researchers really looked at, well, how do we get this subscapularis out of the way to perform the surgery, but reattach it so that it can remain functional, because it is going to be really important to give some anterior stability to that new replacement, and then also for function. We use a lot of internal rotation during our functional activities. So there's several different ways. The inferior fiber release is one procedure that they may utilize, where they'll come in and they'll resect out kind of the lower portion of the subscapularis. They found, remember I said it's a biphasic muscle, that upper footprint, upper fibers of the muscle tend to be a little thicker and wider. So if they can peel off the bottom ones and move it out of the way, they can gain access to the joint and then reattach it. It tends to have better load to failure. So that means once it's completely healed, that musculotendinous junction and attachment on the bone can generate more force before it would disrupt. And that's good, not the disruption, but the fact that it can generate more force. Osteotomy has previously been utilized, where they are going to resect out a portion of the bone, and the research is actually saying that that's being utilized more commonly because they found that bone-to-bone healing is stronger and heals more quickly than muscle to bone or tendon to bone healing. So the peels and the tenotomies, these lower two, some of the research is saying physicians are starting to move away from, because they require more time to heal and they may not be as resistant to rupture. So this might explain some of the differences that you see in rehab as to when you can start stretching to gain that external rotation and when you can do active internal rotation, based on the stability that they feel they achieve depending on which approach they used for that subscapularis. The anterior superior approach is going to come in a little bit differently. So they're still trying to gain more of an anterior access to the glenohumeral joint. If we look in this bottom image, we have our anterior, our middle, and then our posterior deltoids. When they come in for this approach, they're going to come in closer to the acromioclavicular joint, and they're going to go, oops, I didn't draw that very well. Let me erase that. Sorry. Here we go. Okay, so when they come in to do the anterior superior approach, what they're going to do is come in more like here, going through that anterior deltoid muscle. So in the top image we see here, they actually cut that anterior deltoid and then separate it in order to gain access. Now in this particular approach, they're coming in, a little more from the top here. So if the patient doesn't have an intact rotator cuff with the reverse, that's not a problem. The rotator cuff is probably torn and frayed. They need to debride it out of the way anyway so they can gain access. The downside is that it does cut through the deltoid muscle, so that's going to need significantly more time in order to heal. So active range of motion of any type of the shoulder may be delayed in these patients, and then it may be more conservative as you look at progressing them. There are other concurrent procedures that the physician may perform once they get into the joint. They're going to debride out, maybe try to repair that rotator cuff, as well as several other procedures in order to try and maximize the function and restore some more stable arthrokinematics in that joint. One of the procedures that they might do is called a latissimus dorsi tendon transfer. And I think all these procedures, as I was reading more and learning about them, are so important to understand what our physicians are actually doing during our rehab, because it explains to us why protocols may be slightly different, why progressions and improvements of each patient may be different, right? The shoulder may become like the knee, where everyone's comparing their degrees and their motions. But with the shoulder, we're seeing there were so many little differences that have a significant impact on the rehab that we need to understand. So the latissimus dorsi tendon transfer, it totally makes sense. You're going to see this probably the research that is more commonly with our reverse shoulder arthroplasty patients. And here's why. That typically our teres minor and our infraspinatus, originating here on that infraspinous fossa and then the edge of the scapula, come around posteriorly to that greater tuberosity, and they're our external rotators of the shoulder. External rotation is very important for a lot of different functional activities. Well, if the individual has a tear that is not repairable of those muscles, now what's going to perform external rotation for them? The deltoid can function as an external rotator, but that doesn't make it very strong. So the physician may decide to, if we look here at the image on the left, take this latissimus dorsi off of its attachment on the intertrabecular groove. So typically the deltoid comes posteriorly and then it wraps around, right, from underneath here to be an internal rotator. So what they do is they slice it off, they tag it, and feed it back under behind the humerus to come out the other side. So they take this attachment off, feed it back under here, and now they pull it along the lateral side to reattach. So now it's become an external rotator. How amazing is that? It's still, because of its angulation, it can still function as an adductor and extender because we do need strength of those motions, but it's showing in the research that there's a significant improvement in function of these individuals in terms of satisfaction, strength, as well as range of motion, if they do that lat transfer. Now, there is going to be a little learning curve for the patient because of recruitment of the muscle will be different. So you do want to know if they have this procedure performed, maybe you need to use a little biofeedback for recruitment. Another procedure that might be performed concurrently is a long head of biceps tenodesis. When we look at the anatomy in this area, the long head of the biceps on this bottom left image is coming up in this area, and in the top image we see that inserts on the supraglenoid tubercle. So it is a shoulder flexor as well as an elbow flexor. Because of its intimacy and location, that it may become deteriorated in some patients and damaged and not functional as a shoulder flexor if they have significant arthritis or arthroplasty of the joint. They've also found that some patients, after total shoulder replacement, they start to develop a biceps tendonitis or just some general anterior shoulder pain. So the research is showing that what some of the physicians are doing is they're taking this biceps tendon off of the supraglenoid tubercle, and they're moving its insertion more distal here, closer to the lats and the pecs in the intratrabecular groove. So now it's just going to be an elbow flexor. And the research seems to be saying that when they do this, it alleviates some of the anterior shoulder pain that some patients were experiencing. If a patient had this procedure done, that does mean in your rehab that they are going to be limited in their elbow flexion. So we know that when we're rehabbing a patient for any shoulder pathology, we want to keep the range at the elbow and the wrist. If they had the biceps tenodesis done, you're not going to be looking at doing active elbow flexion immediately, and you're going to be very cautious with going into full elbow extension as it may stress that repair. So we need to know if this was done so we can time appropriately that active strengthening of those biceps. Acute post-surgical management for patients with shoulder arthroplasty, regardless of the type that they're having. We tend to see that there's a little bit of a shift occurring because of bundling of payment and more use of ambulatory care, that these procedures might start to to be seen more in the ambulatory center without a significant hospital stay. They're predicting that as we move closer to 2030, that it's going to be more common to see total shoulder replacements and reverse shoulders done more in a younger population who might be more appropriate candidates to just discharge home. What this means for those of you who are in the outpatient setting and home care is that you're seeing patients who are more like an acute post-op patient that you would see in the hospital, but you're seeing them sooner in these other settings. So regardless of the setting that we're in, we need to be more cognizant of how soon post-op they are to monitor them for any immediate early complications. Patient education then is going to be important. They may not be coming where they had rehab in the hospital, that we might be seeing them for the first time in that home care or outpatient where we need to go over the different precautions, make sure they can put on their sling appropriately, look at how are they getting in and out of bed. These are opportunities for pre-op education also if you're seeing the patient. How are they going to do their self-care? Do they need any adaptive equipment so that they don't compromise that surgical repair? Post-operative management is going to consider the different surgical procedures that the patient had completed. We're always going to follow the physician orders as well as their protocol as we're progressing. Some of our patients may present with a surgical drain that's inserted. Looking at this top image, the patient had their shoulder surgery completed. They have the small catheter that was inserted at the time of surgery, and then this may be connected to an accordion-like or a bladder type of reservoir that's draining the excess fluid and blood out of the area. We can see in the bottom image here that despite that, he still has a significant amount of drainage that's occurring, that's placing pressure on those healing tissues. So the physician might want to use a catheter to remove that, to take some of the stress off those tissues. Generally speaking, what seemed to be the guideline, and you look at your specific physician, is that post-op day 1, if they have less than 30 millimeters of drainage in 8 hours or 100 millimeters in 24 hours, that's when they're going to use their guide to see if they can safely remove that drain. The research didn't fall either way in saying, yes, the drain is really beneficial, or no, it has zero effect. Possibly some of the research said that it may decrease the risk of hematoma formation, but it does seem to be more physician preference related. Pain management for patients post-operatively is important. The physician is going to consider this pre-operatively and intraoperatively to manage how he's going to manage pain post-operatively to try and decrease that use of narcotic medication. So we're going to see multimodal management. What tends to be utilized with shoulder arthroplasty is either a peripheral nerve block, where they are going to go in the interscalene region or maybe supraclavicularly. For that individual, they'll use ultrasound guiding in order to inject into that area preoperatively to create some pain relief and management during surgery. Patient-controlled analgesia pump the patient may have post-operative, where they can click the button to dispense the medication. And then some physicians intraoperatively, they're going to inject different pain medications directly into the surrounding tissues that may have been irritated during the surgical procedure. And then there would be carryover of that pain relief into that immediate post-op period. I just want to bring up that the research is finding that individuals who have the interscalene and supraclavicular peripheral nerve blocks, there are some very specific complications, or side effects, I should say, that we do want to monitor those patients for. Because of the proximity in this area to the brachial plexus as well as the cervical sympathetic region, that there's a very close connection into the head and neck area. So some patients may present with what's called Horner syndrome. So when you're assessing them, don't forget to come up the chain and look at the face. If you start to see meiosis, which is a pupillary constriction, if they have ptosis, which is an eye drop on the same side of the surgery, or anhidrosis, where they're not sweating, it could be indicative of a side effect of the medication into that sympathetic system. Also, what they're finding in some individuals, either they are saying either maybe because of the positioning during the surgical procedure or because of the tight binding of the brachial plexus in that area, along with the different subclavicular, subclavian structures, that it could cause the Betzel-Jarisch reflex. That's where the patient may be experiencing bradycardia and hypotension, and what they're connecting it back to is that the peripheral nerve block and the positioning and surgery somehow irritated the left ventricle, so they're not having sufficient cardiac output. So if your patient is, presenting with these symptoms, you really have to tease out cardiac versus potential side effect and referral back to the physician. Another aspect that I want to bring up is the decreased respiratory capacity in patients who undergo the peripheral nerve block. The research that I read is that there's about a 25% decrease initially in respiratory capacity in patients who undergo that peripheral nerve block. And that's because the phrenic nerve overlies that area very closely, so it might have a little decrease of its functioning during that time. So you really want to be cautious in your patients who maybe are obese to begin with or have respiratory compromise. Really look at that incentive spirometer use. We're going to be even more cautious in avoiding potential complications of atelectasis or pneumonia. And then you're also going to assess down the chain with grip strength, because if that lower brachial plexus has excessive involvement during the nerve block, we may see a decrease in grip strength. And most of these things are going to be transient, but you want to know what they are, so as you're assessing the patient, you can determine when you need to communicate with other health professionals and the patient may need additional attention. Have to mention tobacco use when we're looking at surgery, that the research has shown, it was a 2018 study that looked at individuals who were undergoing surgery and their smoking habits. They did find that they had longer hospital stays, needed more pain medications, had higher pain scores. On the positive side, they did find that just 3 months of ceasing smoking or tobacco use, any type, really had a positive impact in better outcomes for these patients. And also it can impact their healing. So something to consider in your preoperative instruction. We mentioned deep breathing exercises, why we're going to be particular with those, especially if they have the nerve block. But in all your patients, this is something to incorporate with the shoulder arthroplasty, because many of them are going to preoperatively have rounded shoulders, forward head. So we want to look at restoring alignment to increase respiratory capacity for those patients and look at maintaining that in their positioning to improve their oxygenation, endurance, and we know the linkages there. When we look at complications that patients may experience following shoulder arthroplasty, the research is still emerging. Here's some of the challenges in the research is that it wasn't until 2011 that the ICD-9 codes separated out total shoulder arthroplasty from reversed. So a lot of the data is starting to come up now. What they tend to find is, similar complication rates in both the hemi and similar complication rates in the hemi and the total shoulder, and then as of now, less complication rates seem to be occurring in that reverse, but it's also not utilized as commonly. So I think we're going to start seeing the research emerging more, looking at the complication rates. The potential complications that patients may experience could be short-term or long-term following their shoulder replacement surgery. One complication that you want to monitor patients for is a periprosthetic fracture. This is just showing a general bone fracture here. What we're going to look at is concern when the prosthetic component is inserted with particularly the total shoulder arthroplasty, that they could sustain a fracture of the tuberosity. So that's why they're looking at those, developing different stem lengths to not disrupt that bone as much. The research tends to say that there is a low risk of those periprosthetic fractures, but it can happen. A lot of times it does happen in the OR, so the physician will address it right at that time. What we might monitor the patient for during our rehab that we'll see is a scapular fracture, particularly where that spine of the scapula comes in to this acromion. In this region is where you're more likely to see the fracture occurring, and this may be a little more in the reverse arthroplasty because it's already weakened because of the abnormal mechanics preoperatively. It seems to be that at the point when the patient is starting active range of motion, if the alignment isn't appropriate or the mechanics aren't appropriate with either the total shoulder or the reverse, and we have that superior translation, that may cause this acromion fracture. So they've said, generally speaking, around 3 months. And the way that you might know this has happened is not only the pain the patient's experiencing, particularly if you palpate along the spine to that acromion, but you're going to see a sudden decrease in range of motion where they're progressing, and then there's a sudden decrease that something has changed. So this would warrant referral if you're concerned about this back to the physician. Infection, we're always monitoring our patient's incisions. This patient has a very nice incision here, so that's our anterior incision on the shoulder, no concerns here of healing. What we're looking at when we're monitoring patients and the concern where there may be a little increased risk of either superficial or deep infection is because there's a specific bacteria, Proponium bacteria, that is located on the skin. It tends to be more common in areas like under the armpit. So if generally it naturally places the patient at an increased risk of infection if there's not good preoperative cleaning and cleansing of the area intraoperatively. So your patient, when you're doing your preoperative education, if you have that opportunity, if they don't have good range and they have a painful shoulder, how are they cleaning under here with all those pre-op washes? Maybe they need adaptive equipment. Maybe you just need to help them understand that it really is important. Teach them different techniques or have someone help them so that they understand to decrease that potential risk of infection. Deep infections can occur. We're going to monitor our patients for more systemic signs, the night sweats, fever, and chills that might be indicative of a deeper infection. This might be the patient as they're rehabbing that they start to have a gradual increase in pain and stiffness, decrease in range of motion. They tend to say that the infections of the prosthetic components in the shoulder tend to be later diagnosed compared to hip and knee because we're not weight bearing as much through it, and the weight bearing doesn't exacerbate the pain. It's a little easier to not use your arm. So this is something that needs to be monitored for and then referral made to the physician if necessary. In terms of neurologic injuries that may result following the shoulder replacement, if we look at our brachial plexus, we'll start on the image on the left. We see our brachial plexus coming down in this region, and this patient is in position to expose that anterior shoulder region where they'll go in for the procedure. Here's our humeral head up here. The concern is that we have a lot of vasculature in this area. And on the right-hand image, just above this blue line, is where we see that axillary nerve coming around. So potentially when they're in here doing the surgery and they resect out this humeral head, if they're using cement, that the heat generated, it's an exothermic reaction, can potentially damage that nerve. And they also found that this radial nerve here, I'll do dots because it goes posterior. But remember that radial groove on that posterior axis of the humerus that they say sometimes with a long stem that has cement in it, that from those radial foramen, that some of the heat can leach out and damage that radial nerve potentially for the individual. Also, there can just be tractioning on that brachial plexus from the positioning during the surgical procedure. For the most part, these will be transient type of injuries, but when you're assessing the patient, you do want to look at the entire upper extremity to see if their functional strength and sensory changes fits with the diagnosis. So you're going to monitor down that entire upper extremity to see if potentially there is a nerve involvement. Instability, we're also going to monitor our patients for, particularly when we're doing that passive range and they're starting with their active range of motion. It seems to be indicated in the research that, again, when the patient is starting with that active range is when you're going to see that instability if alignment wasn't achieved, if the muscles are not the appropriate length tension relationship and strength isn't being regained, where you might start to see some of that instability. So they say generally 3 months, maybe to 6 months out, where you might to start see either due to patient risk factors or surgical technique. Anytime we have anything where the patient's response just isn't as we expect, we're going to refer back to that physician. The instability that you commonly see is going to be an anterior instability. Seems to be most common because in this anterior region, we can see here this has subluxed out. Maybe that subscapularis, if it was reattached, maybe it has ruptured off. Maybe the deltoid tensioning isn't appropriate, and that patient may need additional surgical procedure in order to manage that instability. When we look at joint protection, our precautions, it's important to not stress that subscapularis region, to just allow all of the structures to heal, particularly if the patient does not have a rotator cuff that's controlling the stability. What we're going to look at avoiding is internal rotation, adduction, and extension. So this combination of internal rotation, adduction, and extension can lead to that anterior subluxation. And you might be thinking, when would I ever do that? Well, if you're going to even tuck in your shirt in the front, your humerus, right, is closer to extension than flexion, and you're adducting and internally rotating. Definitely reaching behind. Even if the arm is at rest, moving the body can put the arm into that position. So we're going to be cautious in educating our patient even when they're readjusting in bed, or just letting that arm drop behind posterior, the thoracic cavity, places it with that anterior stress. For this reason, many patients are going to be presenting with a long-term use post-operatively of a sling, somewhere between 6 weeks or maybe even more if they have the reverse shoulder arthroplasty. And the key here is to really protect that subscapularis reattachment to avoid the joint subluxation, to really be cautious in that repair to allow stability and healing to occur. Shoulder sling, we know, most commonly not donned correctly on our patients. The patient on the left-hand side here, he has it on right. Patient on the right-hand side, very happy with that selfie, but that sling is not on correctly. Look at how far extended this shoulder is, and they're in internal rotation, and it's adducted across their body. So you can almost see here the anterior stress. So we always want to tell our patients that even when they're in the sling, seeing that elbow is really important because that keeps them in more of that flexed position. Some physicians may put the abduction wedge, like when there's a rotator cuff repair, so that it does not stress that shoulder region. With that positioning, it's important to remind our patients all the time to make sure they can see that elbow, whether they're in that recliner, the arm could drop back. We want to avoid cervical stress in the area by having that sling on appropriately and make sure they keep their shoulders back. If they do have a nerve block, they have procedure, they go home, they were maybe not, so cognizant after that, but they're not feeling their arm maybe as they're sleeping shifting out of that sling and into an awkward position. So maybe family education is also necessary. In terms of mobility precautions, they're going to, usually in early rehab, we're going to avoid those combination of movements that we just discussed, as well as no pushing, pulling, or lifting. Remember those compressive and shear forces across the joint. And then in later rehab, we're going to avoid this movement of the abduction with external rotation. It creates a long lever arm that, again, stresses that anterior capsule. You might think, when on earth am I going to do that? But if you're going in a cabinet to get something, you're just going to get that hanger or something off a shelf, you might be going up into that position. Glenoid component loosening is something that patients need to be monitored for. This is a long-term complication. It tends to be more common with the total shoulder arthroplasty. What happens with this is in the total shoulder arthroplasty, that restored the normal anatomical. So we have a concave glenoid fossa that has the component in it. What happens over time is that it starts to loosen in that area, and it can lead to instability of the entire component tray. How this actually happens is more of my beautiful artwork. So the best way to understand the glenoid component loosening with the total shoulder is called the rocking horse phenomena. And if you remember the old-fashioned, please, I hope there are some of you out there that remember this with me, I'm dating myself, those beautiful rocking horses where literally you just go back and forth, you lean forward, the back comes up, you lean back, the forward comes up, it rocks back and forth. Well, imagine that applying to the prosthetic humeral head on the glenoid fossa. Every time you move your arm, those compressive forces against the joint are creating that rocking horse. So if we look at my image on the bottom left, when that individual moves their arm and we have contact on this left side of the humeral head and the glenoid fossa, well, now this right area, we're going to get lifting. They come back to midline. The compressive forces are great, direct into the joint, so it sets the glenoid component back in. Then they move their arm the other way, and we have force here, and now we have lifting on this opposite side. So it's literally kind of wobbling that component. What happens over time is that because we have that kind of rocking or wobbling of the component, the rocking horse phenomena at the interface between the bone and the polyethylene, we start to get wearing. And it shifts the alignment also of the glenoid head, so maybe we get a little wearing on that side. Now we have these little debris particles in the area that the body is going to recognize as foreign. It is going to start to create osteolysis, breaking down of the bone in the area, and it leads to that aseptic loosening. Aseptic meaning without an infection. I couldn't find a shoulder with this, but this is a hip, and if we look in this area where the arrows are, we're seeing that aseptic loosening where the lysis and deterioration of the bone around the prosthetic makes it unstable. And that ultimately leads to failure of this prosthetic that needs a revision. What they tend to see in individuals with the reverse shoulder arthroplasty is called scapular notching. In this component, we said that the axis of rotation has been moved inferior and distal in this top left image, so we have more of a lower and medial axis of rotation. What happens if we look at the center image is right in this area where I'm drawing this wedge, just below the glenoid fossa on this lateral border of the scapula, because the articulation has moved inferior and medial. Look at this left image. This is terrible art, but it'll give you a giggle and conveys the point that this medial lip here of the prosthetic component starts to wear out the lateral border of that scapula. So it's median distal, that's great for stability, but then they find with every time the person adducts, you get that little extra rubbing and it starts to wear out that slight edge. What they're finding over time, the research is really up in the air about what are the impacts of this. They don't have a lot of long-term research, and I looked for studies. What they start to do is they grade the notching to see how much of it there is. Some of the research studies say, it doesn't matter, the patients are still doing fine, it's wearing out, but they're okay. Others say that if it wears in far enough here, eventually it's going to loosen that big glenosphere that's on here. Or it may rub away enough that you have those large screws coming in, it may loosen them. So there's a concern. Really, the evidence ended up saying there is no definitive evidence either way. The jury's still out, but this is something they're going to monitor patients for to see the long-term effects. Moving on to rehabilitation of our patients following shoulder arthroplasty. They are going to go through several different phases of their rehab. We also need to consider our functional progression within that. And then we're going to take a look at return to sport activity, as well as some outcome assessment tools that you can utilize. On the last page of your course notes packet, the printable version, there's a sheet that will have references to any assessment tools that I mentioned. So if you do want to use those or take a closer look at them, you're able to easily access those. As we look at our post-operative arthrokinematics, we've already discussed some of the differences between the total shoulder as well as the reverse shoulder arthroplasty. It is important that we do understand exactly which procedure the patient did have done, because it's going to give us some information as to how much we're focusing on that rotator cuff versus the deltoid muscle during our rehabilitation to restore functional movement. They've done some interesting studies where they looked at how patients utilize their upper extremity following a shoulder arthroplasty. We know that we have our normal scapulohumeral rhythm, that as the patient abducts or flexes their upper extremity, we have a certain amount of glenohumeral compared to scapular rotation that occurs in a different proportion that allows for full functional upper extremity range of motion. When we look at patients who either had osteoarthritis or a severe rotator cuff pathology, they probably had a lot of time leading up to their surgery where they were not using normal movement patterns. So they developed muscle tightness and weakness, substitutions, compensations, and now all of a sudden they have this new shoulder replacement. It doesn't mean they automatically know how to recruit those muscles appropriately. So they looked at a study where they took individuals in 2017 who, it was very small cohort, but it was interesting what they did. They had 14 patients who underwent a total shoulder arthroplasty and 9 patients who had a reverse. And they looked at them lifting to 90 degrees, 60 degrees, 30 degrees, and they looked at that scapulohumeral rhythm and dissociating the scapula from the humerus, because now that they've had surgery, that is possible. They should be able to move in a more normal and typical movement pattern. What they found, though, is that many of those patients had significant upper trapezius, latissimus dorsi, serratus anterior, muscle spasms and shortening from years of inappropriate mechanics, that now when they moved, they actually used a significantly greater amount of scapular upward rotation versus glenohumeral flexion or abduction during their functional activities. And this is important for us to consider. Now, when we're rehabbing our patients, we're going to look at quality of movement as well as quantity, and there might need to be some muscle re-education in there. We might need to work more around those scapular stabilizers, restoring those force couples appropriately, restoring muscle length so that they can recruit the force couples. And it's not just, oh, they have motion back, they know how to use it. So that might be an important part of your rehab of your patients. In terms of how much range of motion we can expect, there's not a magic number. What they are finding in the research is several consistencies. And the big consistency is that you're not expecting to get full 180 range of motion out of the patient in full rotation. Generally speaking, what most of the research tends to agree on is that most individuals are going to achieve between 80 and 120 degrees of flexion and about 30 degrees of external rotation. So that's going to allow for functional upper extremity movement. Well, 120 isn't full range and 80 is not even close to it. They're getting those arms up enough that they can perform many different functional activities. For example, some different studies that look at how much, what's the minimum range of motion to do, let's say, dressing activity. It's about 105 degrees, give or take, so that these patients are falling in a range where they are becoming more functional. Also, the research says that there's a huge variation in what can be achieved. But generally speaking, this is about the ranges that you're looking at achieving. I looked at some different studies that analyzed specific diagnoses to see if there was a difference in the range of motion that's achieved. And it was actually really curious that whether the patients had a fracture or a rotator cuff tear, that they were achieving somewhere between 100, 130, 100 degrees of range of motion. So they're kind of falling right in those ranges. They're also finding that there's a variation in the amount of internal external rotation that patients are achieving. And when I looked at these different studies, and I was trying to find like a great statement I could give you guys in conclusion about the research. One consistency that I saw is that generally speaking, if you looked at pre versus post-op, and this is just me running the numbers, most patients had about a 50% increase in their range of motion. So for example, these patients went from 71 degrees to 130 degrees, that they went from 42 to 100 degrees. So they saw about a generally 50% increase. Don't hold me to that, but it might be a point of conversation with some of the physicians that are referring to you. What are they saying as gains, if it's not one set end point that you're shooting for? When we look at the strength that's achieved for patients following their shoulder arthroplasty, particularly with the reverse shoulder arthroplasty, because they don't have all of that rotator cuff, we're looking at the change in those mechanics alters the deltoid alignment to give that better mechanical advantage to perform flexion as well as internal and external rotation. Because of that non-anatomic design, that external rotation might be enhanced from that latissimus dorsi, so that patient may need education on recruiting that lat as their external rotator. And then don't forget that subscapularis muscle that is often preserved is biphasic, that it's going to also contribute to abduction, adduction, as well as rotation. So there should be some significant strength that can be achieved despite the loss of that rotator cuff. So there should be some functional movement patterns that can be achieved. Considering phases of rehabilitation for patients, we're generally going to see that individuals are going to follow a very specific rehab protocol that tends to be more conservative at the beginning because of the different rotator cuff repair, tendon transfers, there's concurrent fractures in other areas that need to heal. All of that's going to change the timeline slightly. Generally speaking, most of the protocols that I looked at and research that I read said that most patients, by about the 3-month post-operative time, they're starting to feel kind of comfortable with the shoulder, that they're having some range of motion, but they're still presenting with significant weakness. By about 6 months, the pain tends to have mostly subsided for the individuals. Their strength is progressing to about 2/3 of what's normal. And then by a year out, most individuals, they're pain-free. Their function and gains have plateaued to what it's going to be. That's kind of a loose timeline, and that is a long timeline that we're looking at if we were to compare the shoulder to hip and knee rehab, where they're ambulatory and off that device much earlier. So this is more of a slow, steady progression. The rehab protocols, the times, and the interventions are going to vary, again, because of all the different concurrent procedures that are done. One constant is that the reverse progression is definitely slower. That it is everything's just going to be a little bit later that you're doing with those patients. Now, there's limited research that exists on very specific exercises that are going to be performed. It's not like this is the magic exercise to perform at this week that does it, makes your patient successful. But what we tend to start seeing are different consistencies that are emerging. So what we're going to take a look at is what I found from my research and looking at different protocols that are out there. It is in no means meant to supersede the protocol of the physician's providing you. It just kind of gives us a starting point to have a discussion about some considerations you should have during the different phases of rehab. Some sample rehab phases that we're going to see, and we all know that having a protocol does not supersede our clinical judgment, that we're considering that the different exercises and stretches and timing of that we do is really based on the different healing that's occurring in the tissue. So we're kind of seeing that, and I remember teaching, always telling students, in your mind's eye, you have to see what's going on at the, physiologic level with the healing, at the anatomy level with the tissues, how your patient's responding, the feedback they're giving you, and put that all together with what interventions you're performing. So generally speaking, what we tend to see in terms of the phases of rehab, that early phase 1 is going to start post-op day 1. The goals at this point in time are to really just maintain the integrity of that new joint, maybe start to look at elbow, wrist, and hand range, trying to maintain that. Look at function in terms of ADL modification so that they are capable of protecting that shoulder and still functioning. Phase 2, at about that 4-week mark, give or take, is when we're starting to look more at passive range of motion and starting some active range of motion. And we want that to occur with normal kinematics, normal muscle recruitment, and activity retraining starting. By phase 3, at about 6 weeks out, we're looking at more functional activities being incorporated, starting to gain strength. And we know that gaining strength doesn't mean all of a sudden you're using weights in your rehab. Based on the patient, gravity might be the resistance that they're using. And then by phase 4, 12 weeks and beyond, we're looking at really increasing power, endurance, weight-bearing activities for that patient. We're going to take a look at each phase, some of the different precautions that you may have during those different phases, and some of the exercises that you might be incorporating. Again, this does not supersede a physician protocol, just gives us a starting point to have a conversation to consider what's going on with the patient during the rehab. So this phase 1, we're looking at that about that first month post-operatively, where the patient is wearing the sling to protect that surgical repair that has occurred, as well as those new prosthetic components. We want to make sure that the patient is avoiding those positions of the shoulder extension, adduction, and internal rotation. At this point in time, right, you might be saying, well, he's abducted, but if he was to weight bear into that extremity to stand up, he's going into that adduction internal rotation. And if you think the patient may be unstable with their balance, that can shift the forces through that extremity. So in this early phase, this patient is not putting any weight through that extremity. They should not be using it to support them to push up. They shouldn't even be using that just to make adjustments in bed. And that may not be something that they cognitively really consider, that if you're in bed, you're resting, you have your arms supported, and you just want to shift in bed, well, when you just let that arm fall back and you move, suddenly now I've put weight through that extremity. So we're really going to emphasize and look at activity modification and environment modification if needed. No pushing, pulling, lifting at all, and avoiding those positions. The patient is always going to make sure that they can see that elbow. During phase 1, some sample interventions that you might be performing with the patient in the protected ranges that your specific physician indicates, or might just be passive range of motion, just to maintain some of the extensibility of those tissues around that shoulder. And then we're looking at active range of motion more distal on the extremity. You're going to be cautious If your patient did have a latissimus dorsi transfer or a biceps transfer, that when in this image you're performing that shoulder flexion range of motion, you might need to have this elbow flexed to take some of the stress off of those repairs. So you're going to be cognizant of that. Pendulum exercises might be permitted at this point in time. You're probably using modalities like cryotherapy to try and control some of the inflammation and swelling. And then we're looking at that scapular alignment for the patient. Again, for a long time, they probably had inappropriate mechanics, so we're going to try and get them back to that scapular setting, that scapular alignment, and dissociating that from that humerus while we are supporting that. Anytime you have this patient supine, this gentleman, if you look at his muscle and tissue mass, he's not a typical older patient that maybe had a fall and had a fracture, or older patient who had a cuff repair that was not successful and now had a reverse. They usually have a lot more thoracic tissue, so when they lie supine, their humerus isn't in line with their body. It may be dropping back. So you're going to make sure, if you need to, that you're always going to have a towel posterior, imagine this is here, keeping that humerus up in alignment. So when you come back down from your flexion range, you're not dropping past. So just be aware of that in their alignment. We're also going to consider using scaption for our range of motion. Scaption, I can tell you, I don't remember it existing way back when I was in school. This is why we need to stay current on so many things. But scaption is such a great plane of movement. I think now it's just standard for everyone. It's that plane of about 30 degrees abduction and flexion, so that we have alignment in that scapular plane of our humerus for appropriate length tension relationships and alignment. So she has them out, not quite scaption there. It's about appropriate. Again, here you're going to be looking at putting a towel roll posterior to keep that extremity up in line with the thoracic cavity. Scapular strengthening might be important in this first phase. We're looking here. This patient has this significant forward head posture. Look at how far forward and the spacing we have in our scapula here. Alteration or lack of lordosis in the cervical spine. So this is your patient that's been protecting and substituting. So we're going to look at maybe different interventions, modalities, and stretching for the scapular region. Those scapular muscles do attach up into the cervical area, so we're going to be cautious of that and looking at alignment for those patients. Remember that many of the patients with osteoarthritis in their shoulder probably have it in their cervical spine also, so that might be contributing to their substitutions and their weakness. So we need to bear that in mind to be holistic in our rehab for that patient. As we move into later phase one, we might start looking more at those scapular setting exercises. This is around a 2 to 4 week time period, progressing the ranges of motion that we're doing passive range of motion in. Some physicians might start allowing some active assisted range of motion in either the scaption plane or forward flexion. So maybe the patient's doing clasped hand, low range of motion. We want to make sure that that scapula is supported. So maybe they're starting that in supine. Maybe they're starting some gentle, table slides for range of motion. But we have to be really cautious with all of these that we're not giving a compressive force into that shoulder. And that we make sure right from the beginning when they're starting range that we're getting that dissociation of the scapula from the humerus, because we know the research is showing the tendency is for them not to do that. The dynamic hug exercise, I don't know how many of you are familiar with that or utilize that in rehab. It is not being utilized on this patient population at this time, particularly early in rehab. Dynamic hug is traditionally where you put TheraBand around the back and you kind of hug down and in. The thought is traditionally that you were getting serratus, that you were doing protraction as you kind of did that. And I bring it up now because we're talking about scapular exercises. Dynamic hug, they've done a lot of EMG analysis on, and they found that it's not really working the serratus, that it tends to more so be working the subscapularis muscle. You're getting a lot more internal rotation with it. And remember, we said that we're being really careful with that subscapularis during this early rehab, very protective of it because it's so important. So you don't want to be using that dynamic hug even without resistance. That if you're looking at strengthening that serratus anterior, you want to go with more pure scapular protraction. As the patient moves into phase 2, so they're about a month out from their surgical procedure, what's interesting is that most of the protocols say that progression for patients following arthroplasty of the shoulder, it's not as much based on like a number of weeks, that there's consideration of that because it's indicative of the healing that's occurring in the tissues, but progression through the different phases of the protocols is more focused on what range of motion has been achieved. How much pain-free range are they having at that point in time? So when you look at the protocols, you're usually going to see that the progression is more based on degrees. So I have some examples included in all these slides. So as that patient is gaining passive range, they're about a month out from their procedure, that they may be starting to be weaned from their sling. If they're a total shoulder, the reverse is probably still wearing it. And something that's brought up frequently is that when you're weaning the patient from the sling, that they still really need to be cautious of avoiding those reaching behind the back or in front positions of the shoulder that can compromise it with instability and potential subluxation. And when you think about your upper extremity imbalance, that right? If you're in a big crowd, someone bumps you or you're turning and you're going to reach for something, you may move into those compromising positions. Or if you fall and go to protect yourself, you're going to move your arm. So the concern is it could disrupt that new joint. So some physicians say, okay, you can wean off of the sling when you're in safe home environment, but if you're going to be out in a crowd, I want that sling back on. And to really, as you progress with range of motion, like all patients, you're going slow and steady. These patients a month out, they're not pushing up in bed or from the chair with the arm. They're not weight bearing through that upper extremity to adjust their positions and monitoring that reaching movement and cautious. So even when they have the sling off, they really need to be aware of this to protect that joint. In terms of lifting, some of the protocols say that what they can start to lift in low ranges is about something that's as heavy as a glass of water. So it's just a couple of ounces. Use a little cup or a lightweight cup. As we look at sample exercises that you're using in that phase 2, which is, again, is approximately starting at that 1 month out, you might be starting with active assisted shoulder range of motion, active range in pain-free scaption. So we see this individual using an overhead pulley. He's not, best we can tell, I'd want to see him with the jacket off, substituting with upper trapezius or shoulder elevation. He's in a good position of the extremity. But how did he get his hands on that? Now, when we're educating our patients, again, they may not think of all these things. They may, it's back there. I'm going to go, the handle's hanging down. I'm going to go back and reach for that handle. Well, now I just moved into those positions that are a precaution. So consider, again, educating your patient. Well, how am I going to get the pulley? Maybe the pulley's in front of you and you grab it, and then you start that way. If I have the patient supine, and I'm using the cane for my ranges of motion, that may be appropriate. The scapula is stabilized, so they can do some light active assisted range of motion in that way. We're generally looking still at not allowing that shoulder extension to go past the neutral. And we are going to, at this point, when they're doing more active range of motion activities, we're doing more scapular strengthening, maybe some shoulder isometrics. You might need to be utilizing biofeedback if they're not dissociating or recruiting the appropriate musculature. When you look at progressing your patient with their exercises, there are lots of different ways you can progress a patient. It doesn't always mean putting a weight in their hand, particularly if you're in the home care environment, you need to get a little creative. Use gravity. So maybe we start our patient supine with their active range of motion or active assisted range, that scapula is stabilized. Then we bring them up to that lawn chair position. We're using gravity. It requires a little more scapular control. We can start to look at controlling head alignment concurrent with that. Then we work them into sitting, incorporating all these components, and then standing, where they have to control more of the kinematic chain. So all of those things can be a progression. So as we even add resistance, maybe you add resistance, but take them back down a position. So there are lots of ways you can get creative in terms of achieving appropriate alignment, appropriate recruitment, and progressing the patient's strength. But being cognizant in this population that you're really remembering that scapulohumeral rhythm. As we look at about 6 weeks out for the patient, they're usually off the sling by this point in time. They're starting to do light functional tasks. Some physicians say they can lift up to about 6 pounds at this point in time. Again, they're being cautious with their balance in terms of sudden lifting and pushing activities that can create an aggressive force across that joint and potentially disrupt it for them. So when we look at this phase 3, they're tolerating passive range, active assisted range, isometrics. We're doing active range with this patient. So at this point in time, we might also be incorporating stretching in protected ranges, gentle stretching to try and be low intensity to make gains in our range of motion, as well as starting to add some endurance training in for patients at this point in time. We're still being cautious with that shoulder external rotation. We might be able to start that resisted external rotation in that scapular plane. Maybe we're starting some dynamic stability exercises at a low level for that patient, maybe adding an ergometer in for endurance, but not with a lot of resistance. And then when we get into that late phase 3, we're adding for this patient just more progression of all of our exercises. Something that came up in the different protocols that I noticed is the use of TheraBand. And I couldn't find any good research to support it. Might just be a point of conversation that some of the physician protocols were saying that even at this point, you're avoiding the use of TheraBand, that the concern with the need for eccentric control may not be appropriate yet at this phase of healing for the patients, that they don't allow TheraBand until later in about phase 4. So just something to be aware of. I'm not sure what the references were for that, but it was mentioned in several different protocols that developing that eccentric control, they said using TheraBand for it at this point in rehab may place too much challenge on that new shoulder. As we look at moving on to phase 4, we're looking at more about 12 weeks out where the patient has achieved the range of motion that they are going to achieve. Now we're really looking at gaining their actual strength, functional tasks, and endurance. We're doing more of a dynamic stability at this point in time. As we add that maybe TheraBand at this point, return to function, progressive strengthening, closed chain, more dynamic type of exercises, plyometrics, depending on the task that they are going back to, adding more weights and resistance. And now we're looking much further out, about 16 weeks for these patients. As we're adding those exercises, we may have patients that are returning to different functional tasks. Maybe we're starting to add a program where they're going back to the gym. We're going to particularly be cautious at that horizontal extension or abduction and external rotation combination. We can see here that that will stress that anterior capsule. When might someone be participating in these particular activities? If they're going on an exercise machine to do flies, getting into that position. If they're doing any benching or overhead military types of presses. With functional tasks, just reaching for something or holding something and then turning their body away from it based on what they're doing. So be cautious now. You're emphasizing up here is where we have a concern of potential instability of that joint while it's still healing. With discharge from therapy, patients are going to be at a point where they've achieved their full range of motion, their function has been restored, power, strength, and endurance in order to discharge them from therapy. So what kind of long-term outcomes are we looking at? When I compared the different research looking at functional outcomes for patients who have undergone either the reverse or the total shoulder arthroplasty, the majority of individuals are looking at having improved functional measures and range of motion at the 1, 3, and 5-year mark. There was an interesting study that looked at how patients are performing their activities. And again, they're looking at both the reverse and the total shoulder placements 1 and 3 years out from therapy. They're able to do their different overhead ADLs, combing their hair, reaching for something off the shelf. But when they compared those individuals to controls, they were able to form the activities, but again, they didn't use as much abduction and flexion. They were still using more compensations from the scapula. So I think that's important for us to look at and kind of head off earlier on in rehab, because we know that that can lead to pathology in other areas because they're compensations. Considering activities of daily living and when patients are able to progress to perform different ADLs, we need to consider that early on when they're in the sling, they're utilizing their non-potentially dominant side or their non-surgical side. So maybe they need oversized clothes, elastic waists, things that they can press versus lift to, open bottles and dispense different things. We're going to consider how are they going to feed themselves. They want to start getting back to their functional activities and back out in public. So do they need different adaptive equipment? All things to consider and be aware of. And the research really says, which we already know, that positive reinforcement, having the patient be part of this decision making, empowering them, because this is weeks, months recovery from this procedure. So we want to make sure that they can perform their functional tasks. In terms of hygiene and toileting, we want to consider instructing patients in how to perform this, and this is a good opportunity for PT and OT to interact and collaborate for our patients. Remember, we talked about in the beginning those shear and compressive forces that go across the shoulder. That's why we need to be so conservative with what functional activities the patient can perform early on, because they may think, oh, I'm just lifting up a washcloth. But we're thinking it's not the weight of the washcloth, it's how much stability has to happen in that joint because of the lever arm and the mechanics. So when they're going to wash under their operative side, if they can't lift their arm up, well, maybe you teach them to rest, not wait there, and maybe they step back, and that gives them some range so they can clean. Or maybe they use a Codman's position. Consider, do they need, a raised toilet seat? Maybe they use disposable or flushable wipes for cleaning or for toileting. And consider those reaching risks. Maybe they need to change the orientation of their bathroom. In terms of functional progression for a patient who has a total shoulder arthroplasty, again, you'll see variations, but generally speaking, what we see in that first month, they're able to perform waist level ADLs. So those are things like, reaching just in front of them here. Maybe they can start to wash their hands, or gentle lifting and moving of different objects. About the 6-week mark, they can start some sedentary job tasks because they're allowed to lift light meals, do some light meal prep at this point in time that they can start using. They say in that first month, we start with a glass of water, maybe moving to a pound. In that 6-week, plus time period, we're looking at maybe something that only weighs about 3 pounds. Driving is interesting. When we look at driving, there were different variations. Of course, they have to be off any narcotic medications. But when you look at driving, you may be thinking, well, I'm not lifting anything. But when you're driving, you're putting compressive force through there, and that's a long lever arm, and you need to develop resistance. So what they found with driving in that study that looked at compressive forces, they found with driving that you put about 47% of your body weight, compressive and shear forces, through that joint. So that's why it needs to be considered and cautious with the physician when they're going to allow that. At 3 months out, we're allowing them to do a little more carrying, around 5%, and 6 months is when they can move more towards that heavy lifting. Individuals with the reverse shoulder arthroplasty, that's going to be a little more conservative. They don't have that rotator cuff. That deltoid is kind of learning that it needs to do everything now with appropriate mechanics. So it's going to be more the 6-week mark where they can do those waist level ADLs, seating, personal hygiene type activities. They're still not leaning and weight bearing through that extremity yet, but they can start to do some gentle lifting. They can move to about that 6 pounds worth of lifting more by the 3 months mark, and then 14 to 16 weeks out, they can start doing more bilateral lifting type of activities and more progressive ADL activities and function. As we consider return to work and sport, I really wanted to see, well, you know, what's the max? Like, what can we get out of these new joint replacements? Again, the research is still emerging, but what I did find was interesting was one particular study where they followed patients for 2 to 5 years, looking at the activities that they were able to go back to. And they found that individuals with the total shoulder arthroplasty, particularly with recreational sports, they seem to have better opportunities and more success in returning to sport activities, which kind of makes sense because those are probably your patients who had arthritis or a traumatic fracture. All their muscles are still functional for the most part. So they were probably doing more before, so they're doing more after. What this study found is that those individuals, they had better functional scores. They were able to participate in activities with greater frequency, such as, well, housework. That's not fun, but housework, gardening type activities. They're doing more activities such as higher level sport participation, whereas our reverse shoulder patients, they found that those individuals, when they went back to sport and leisure activities, they were looking at things more like running, cycling, dancing, that didn't really require as much out of the upper extremity, maybe some light fishing. Part of the theory that they came up with is that those patients without the rotator cuff probably were doing more of those lower level activities before, so they're not suddenly going to take up a really rigorous new sport. But that was just interesting to see that the total shoulder seems to have more success in returning to sport. I found a study that asked the physicians now, well, what do you think these new joints are really capable of? And they surveyed 35 physicians in the United States and Europe, and they gave them like 40 different sporting type activities and said, okay, where would you rank these that they're allowed to do it. We say you should do it. This is a recommended activity: swimming, dancing, running. Bowling surprised me because I'm thinking, maybe because I don't know how to bowl correctly. Long lever arm, heavy weight, stress on the shoulder. But they did say, if done correctly, most of the physicians, you got to check, that they can go back to that. I guess maybe you're at a low range. If you were experienced with skiing and golfing, they felt individuals could go back to that. They're not doing rock climbing, gymnastics, football. Again, high compressive sport activities, great risk of subluxation and traction on those joints. And then there was no consensus on a variety of other types of activities. I just thought it was interesting to see where that fell, and you might want to speak with your physicians to say, or know their protocols and what individuals can actually go back to. When we consider our overall outcomes for patients who have had shoulder arthroplasty, they're finding that most of the functional gains are going to happen within that first 6 months, but then up to a year out, the patient is still making strength gains, which correlate to improvements in additional, functional activities. They're finding that there really are similar outcomes between the two different cohorts. When we look at specific assessment tools that we're going to utilize in rehab, there are some standard assessment tools that are utilized in order to gain a patient report of their outcomes, so our patient-reported outcome measures. One common one that's utilized with the shoulder is the constant score, the constant Murley score. This is, in Europe, actually, they say it's kind of the gold standard there. This is a 4-part scale that's going to have the individual rank their pain as well as their ADL function. And then what it does for the strength and range of motion is that they get points for how many degrees of range of motion are achieved, and then they get points for how much weight they can hold. So let's say you give the patient, a 1 pound weight, and you see how long they can hold it. And then for every period of time that they're able to hold that weight, they're going to be accumulating different points. All this goes into a mathematical calculation, and then this is going to give us different insights in terms of the patient-reported outcome measure and how well they are performing that we can use as an objective comparison as they go through rehab. And then you could look at a breakdown of the component scores also. The simple shoulder test is another assessment tool that can be utilized. This is scored out of about 12. And this is going to ask the patient questions, yes, no questions, asking them, can you tuck in your shirt in the back? Could you work at your current job? Are you able, to rest your arm comfortably at your side? A lot of these assessment tools say, can you toss a softball underhanded 20 yards? I don't think I could do that now, so that would have to be like a net negative for me. But that somehow must be relative to shoulder function, because a lot of the tools have that as a question. So it's going to ask the patient about their sleeping ability. And again, it's going to give a score. This tool might be helpful for you if you're looking at functional tasks and what you need to incorporate into your rehab to move them towards certain functional task performance in your goal setting. Minimum clinically important difference, they say, is about 3 points on this assessment tool. The ASES is the American Shoulder Elbow Surgeon Score. So this will be something that you'll see referenced a lot in the research, so I wanted to include it. And if this is information that you do have an opportunity where you're someone who can communicate with the physician to see what their score is, you can use it as a comparison. It's going to use a visual analog scale to rate their pain, and then it's going to ask the patient functional questions where they are going to say, can you put on a coat? Are you able to do your toileting? Can you lift your arm to wash your hair? And then the physician component is looking at strength, range of motion, subjective assessment, looking at scarring and atrophy, and then it's going to come up with a calculation. Generally speaking, the research said the minimal clinically important difference is somewhere between a 12 and 17 point change to let you know that there actually has been an improvement. But I will tell you, there was a lot of variety in the research as to what's minimally clinically important. So it might be a tool where you kind of have to look at each patient individually. The SPOTY index is the shoulder pain and disability index. This is going to have separate sections to it. One looking at pain level, and the patient's going to rank their pain level when they're lying on their side, reaching for something or pushing. And then it's going to have functional questions. So it's going to ask about taking something off of a high shelf, tucking the shirt in the front, reaching into your back pocket. And it's going to have the patient say, well, I had no difficulty with that, or I needed help with it. So when you're picking what patient-reported outcome measures to use, something to consider is, well, we want to know about their function, but maybe are you looking for an opportunity that, do you need family education? Do you need to refer this patient maybe to OT for adaptive equipment? So this one, if they're saying they need help with certain tasks, might give you that opportunity to see if there are more referrals or equipment or assistance that someone might need. The research said the minimal detectable change on this measure, to say that it was a true change or an improvement or a diminishing, hopefully not, is about 13 points. This is an interesting one, the subjective shoulder value, and they have this for different regions of the body. These are called SANE, single assessment numeric evaluation, and they're emerging as a way to kind of get one measure or one value to give you an overall sense of how the patient's doing. And I'll be honest, I read about them and I get them conceptually, and I'm like, really? Does that give us anything valuable? And you'll know where I'm coming from in a second. So if you haven't used these before, it's basically, the official thing is you tell the patient on a scale of 0% to 100%, where 0 is abnormal, 100% is normal, where do you rate your shoulder? What do patients do with that? So some other ways I've heard it posed is, okay, so if a brand new shoulder costs $100, what would you pay for yours right now? Right? That's an interesting way to ask it. And the idea is, if they score high, they're having good, they feel they're satisfied and have good outcome and whatever is valuable for them, versus the other way. So here was my skepticism. So I did some research and I was looking for studies, and I actually found a 2015 study where they took 148 patients and they used this measure, asking the questions, and then they used the constant score, the ASES score, and they compared all the results. And would you believe that they concluded in this study that they were all appropriately reflective of the patient's improvements and had equal validity? Now, I don't know for reimbursement and reporting purposes if this is going to give you enough, but it was kind of interesting, and it might be a tool that fits somewhere into your rehab package. Maybe even if it's just for the patient to see that they're making improvements from their perspective. So how about we look internally to the actual prosthetic survival and to see if the componentry that has been implanted is lasting. The challenge here is that there's not a lot of long-term assessment and outcomes to look at. Number one, the procedures are relatively new, that you've heard me say already. But the other part is, if you think particularly with the reverse, that those patients who have the irreparable rotator cuff tear tend to be older, they're actually outliving the prosthesis. So they're just unfortunately not here to get long-term results. So we're seeing more short-term and medium outcomes. So they're saying that when you look at the research, and I found a study that looked at what are all the different studies out there that we have, that they really have small cohort sizes. There aren't that many studies to pick from. And again, the follow-up is kind of maxing out on the majority of them around the 5-year mark. So they're saying that we do still need more research on this. But on the positive side, they are finding that there are benefits to these procedures. With the reverse shoulder procedure, they're finding that there's about a 93% survival rate of the prosthesis at about 10 years out. There was some scapular notching noted, but it really didn't seem to have a negative impact on patient functioning. What they did find, and this is an interesting study because they took the cohort of patients and they initially looked at them 3 years post-surgery, and they had improved constant scores, improved range of motion, looked great. Then of the patients who were still surviving, they followed them up between 10 and 12 years later, and that's when they found these results. And what they noted is that the individuals who had surgery when they were younger, so in their 50s, 60s, even early 70s, that by the time they aged with that prosthesis, even though the surgical prosthesis remained intact, that they had further decreases in function. So they were attributing that not necessarily to the prosthesis, but more so to the aging process. And maybe that little rotator cuff that they did have left that they were able to use for function now is deteriorated naturally as they aged. So they're kind of keeping an eye on that. Looking at some other long-term outcomes, there are several different studies that were trying to pull that information. Generally speaking, they're finding that there's, almost a 90% survivorship at about the 10-year mark. Another study, found that at 12 years out, if patients were younger, were using their extremities more, they still had good survivorship and, integrity of those prosthetic components. All of them are seeing improvements in range of motion, strength, and function. So they're looking at positive benefits so far from the reverse shoulder repair. Looking at individuals who had post-traumatic, so they had fractures that necessitated their shoulder repair, and they looked at individuals who initially had an ORIF, and then they went on to have that reverse shoulder arthroplasty. And what they found is they had significant benefit. That constant functional score improved. They had significant improvements in that range of motion, looking at about that 50% plus improvement that we were seeing. And this was mirrored in several other studies, that following these patients who opted either initially or later on for that reverse shoulder from a fracture, that they're seeing significant improvement in their function. Patient satisfaction is something that we do need to consider in our rehabilitation, and the physician is cognizant of. So I found several studies that were looking at patient satisfaction with their shoulder replacement. Individuals who were under age 50 who underwent the total shoulder arthroplasty at 5 years out, they are extremely satisfied. Those who were younger that underwent the hemiarthroplasty were not as satisfied, only about a 71%. So if we think about that hemiarthroplasty, if they were a young patient and they were at risk for avascular necrosis of that humeral head, so they had the hemi, but they had an intact glenoid fossa, we said that oftentimes that leads to pain over time. So that seemed to be contributing to the lack of satisfaction. But on the plus side, they did find that the prosthesis was still intact, but the patients were having pain. So it does still give them another surgical option moving forward to go to that total or even further down the road, the reverse, if they need it. For the reverse shoulder arthroplasty, they're finding a 90% patient satisfaction rate at 4 years out. And this was an interesting study, and I can't tell you what to do with this information, but I found the study and it made me pause, so I'm going to share it. They looked at individuals who had undergone the reverse shoulder arthroplasty, and it was comparing individuals where whatever led to their pathology that required the replacement, For some, it was related to a workers' compensation case. For others, it was not. They found that in the individuals where it was related to a workers' compensation case, they only had a 57% satisfaction at 2 years out, compared to the cohort that was non-workers' compensation related, had only a 95%. So the 95% satisfaction was significantly higher in the non-workers' comp patients. Now, I'm kind of glad I can't see eyes rolling or hear comments, because this is what I'm thinking. There's some opportunity there, and I'm going to look at it as a positive opportunity that, I don't know, was it longer and they had more atrophy of that rotator cuff, more complications, maybe surgical, maybe there's an opportunity there in, well, what were the patients dissatisfied about? Is it pain? Is it function? Is it their ability to get back to work? Maybe they weren't as functional, that not dissociating didn't lead to enough function to get back to the job. I don't know. But again, I want to mention it because maybe keep an extra eye on that population and where the research is going in your specific cohort at incorporating some satisfaction questions and really teasing out what's going on to see if we're able to have a positive impact, even more so for that population. Looking at the future shoulder arthroplasty, we've taken a look at different prosthetic components that are utilized now. We've considered the arthrokinematics and how you should be looking at that during rehab as you progress them through the rehab protocols, as well as some of the long-term complications. You're armed with the information so that as the research continues to develop, you can look at it with a critical eye and decide how you want to apply it for your population. And I think it's really going to be interesting to see where shoulder arthroplasty heads in the future. I thank you for spending your morning with me exploring this topic. What are some of the precautions post-operatively after a reverse total shoulder arthroplasty? When we look at the precautions for reverse shoulder arthroplasty, those patients are going to usually be in the sling longer than our patients with the total shoulder arthroplasty because there needs to be more protection to that joint because of that lack of the rotator cuff. So there will be a sling that's utilized to protect that upper extremity. And the big precautions for both types of shoulder replacement are avoiding that shoulder extension, internal rotation, and adduction. So reaching behind the back, reaching across the front of the body like tucking in a shirt, even letting that arm just fall back past midline of the body creates that anterior stress at the glenohumeral joint with a subluxation risk. And those would be the typical standard precautions, in addition to whatever specific precautions the physician that performed the surgery indicates. Because if that patient concurrently had maybe a biceps tenodesis or a latissimus dorsi transfer, there'll be a different precautions or additional ones in order to not stress those particular repairs. Question is, how can you create the space between the humeral head and the glenoid fossa after surgery with exercises, or what exercises will be beneficial after a failed traditional shoulder arthroplasty? In terms of if a patient presents with the rotator cuff arthropathy, where they've had that acetabularization, that wearing away of the undersurface of the acromion, the physician is going to determine if that patient has an intact rotator cuff or not, and then that's going to help guide his decision if that patient should undergo a traditional shoulder replacement, a total shoulder arthroplasty that just restores the anatomic design, and the patient's intact rotator cuff will control the translation, or go with the reverse design if he feels the patient does not have an intact rotator cuff. The actual design of the reverse shoulder arthroplasty components are going to shift the axis of rotation of the humeral head on the glenoid fossa more distal and medial, so that when that bicep contracts, it should help retain the space in the subacromial area. So rehabilitation is going to focus on appropriate strengthening and range of motion based on the procedure the patient has. So the question is, any recommendations with challenges faced from getting protocols from the hospitals or the physicians? My hope with this course is that it'll enhance your understanding of the different surgical options that the physician has and the concurrent procedures, so that it will arm you with the information to ask targeted questions of the physicians and develop those relationships to obtain those protocols. Or if you get a protocol where you don't understand the progression, or it didn't seem as clear why one physician is using a sling so long and another one isn't, the information that we're covering in the course will hopefully allow you to be current with an understanding to ask targeted questions of the physician, which in hopes, along with your existing interactions, will build that rapport to help you get that information you need for your patients. Question is, are joint mobilizations beneficial in the rehab of patient with total shoulder or reverse shoulder arthroplasty? I'll be honest, that is not something that I looked at in the research or came up frequently looking at joint mobilizations. Just in its basic sense, it would probably be a conversation to have with the physician, because if the stability is obtained of an alignment from the prosthetic implant, we don't want to disrupt that, creating too much stress across those surfaces. Let me see. Are there any precautions similar to the precautions that we see with total hip replacement, specific motions to avoid after the shoulder arthroplasty? Each physician will give you their specific protocol and precautions. Generally speaking, the precautions that we see with the shoulder arthroplasty are to avoid shoulder extension, adduction, and internal rotation, because all of those will stress that anterior joint region, which places that individual at a greater risk of subluxation. And then later on, we're going to see a precaution, once active range is allowed, of avoiding abduction and internal and external rotation, because that stresses that capsule. Well, the capsule doesn't exist anymore. It stresses that anterior region of the joint, placing the patient at risk. Do you want to avoid active elbow flexion with the long head of the biceps tenodesis? You're going to follow the specific protocol for the physician that performed the procedure. However, generally speaking, when there is a tenodesis, because that tendon has been reattached to the bone, it needs time to heal. So active contraction is going to be limited initially, as well as stretching. And then oftentimes in those protocols, you see that when you can start active motion, you're just doing real small range isometrics, maybe progressing that very slowly into those outer ranges. The question is, what is the life expectancy of the cemented and uncemented approaches? What the research is finding is actually curious, because both of these procedures are relatively new. The reverse is really new and only was approved by the FDA in 2004 in the US. It was performed outside the US previous to that. But they're finding, unfortunately, that many of the patients are outliving the prosthesis. So there's more medium-term outcomes, not long-term outcomes. The research that I did find, somewhere between 10 years is what they have as in the 90% survival rates for the prosthetic components. And the couple studies that I found that looked at cemented versus non-cemented, they were finding equivalent outcomes. But the research is still going to be emerging, because honestly, the techniques are new and they're continuing to evolve in the componentry, that when you're reading research moving forward, based on what we discussed today, really look at what type of components, what type of fixation, what time period are you looking at? Because if you're reading old research, even if it's only like 8 years old, they may not even be using that kind of component as much anymore. So I wish I had a better answer, but what I can tell you is that they're finding similar outcomes for cemented versus non-cemented at the current time, but they don't have long-term research yet. And the concern is some loosening of the component with the total shoulder and that notching with the reverse they're keeping their eye on. So the question is, what is press fit? Press fit means that when the component has that trabecular surface on it, the intent is for the bone to grow in. So the physician will just remount and literally press that into place using different tools to assist with the force generation to get it down into the canal. But it's literally pressed into place so the trabecular surface can grow in, as opposed to needing cement. The question is, what can you expect for range of motion with the reverse? The research generally says that the range of motion you can expect from either procedure is somewhere between 80 and 100 degrees of forward elevation, abduction, and then to a lesser extent, internal, external rotation for that patient. So the question is, with the reverse shoulder arthroplasty, what muscle groups act as prime movers for shoulder flexion? When we look at the reverse shoulder arthroplasty, it's performed in that patient who does not have a functioning rotator cuff, that supraspinatus is not available to contribute to abduction, so the deltoids are going to play a role. For internal, external rotation, particularly with internal rotation, they might be able to save that subscapularis. There are some tendon transfers that they can do with the latissimus dorsi to restore external rotation. And then they actually find that the deltoid is able to contribute to internal, external rotation also because of the angulation of its fibers. What is the typical longevity of the reverse shoulder arthroplasty in an active patient? Since the reverse shoulder arthroplasty was only approved in 2004 in the United States, we're only about 15 years out now, so there really isn't any long-term data yet on that population. What they say is there is some medium-term data that's arising, and so far is showing at the same point in time, it's still somewhere in the 90% survival rate of the prosthetic component, but they don't have that endpoint yet because it hasn't been around that long. So the research is going to continue to emerge with that population. What is the typical time frame for a post-shoulder arthroplasty patient to be non-weight bearing through their affected arm? You're going to see a difference whether they had the total shoulder arthroplasty or the reverse arthroplasty. Generally speaking, the physicians tend to be more conservative in the reverse arthroplasty in terms of when they're going to allow functional use of that upper extremity, because they get the compressive load with functional tasks that don't even require actual weight bearing. And it could be 2 months or longer that the physician is not allowing any weight bearing through that upper extremity because of that lack of rotator cuff. We don't have that control of the humeral head and that superior translation and compressive forces. So there needs to be time for the prosthetic component to heal. So that'll really vary based on the physician protocol, but we tend to see it be longer in reverse patients where they're not allowing weight bearing versus total shoulder arthroplasty. Which is a better functional outcome between the two procedures? It's actually interesting reading the data that's out there so far. When you look at the procedures, the indications for them are different, and it really comes down to that rotator cuff. So if the physician has selected the procedure that's appropriate for the patient, whether or not they have the intact rotator cuff, the research seems to show that's the first step that we need to be aware of looking at outcomes. When we look at those populations then, they're really showing that for each cohort, if they don't have an intact rotator cuff for whatever reason, and they go with the reverse versus just purely the osteoarthritis and the intact rotator cuff, that both cohorts are showing significant improvements in range of motion, longevity of the prosthesis, and improved range of motion for function. So it's not necessarily comparing apples to apples, because the procedure, which one they should get, is different based on the etiology of what's causing their functional limitation, if that makes sense. What is the range of motion achieved in a reverse? Generally, what the research is finding is that patients have a significant improvement in their range of motion. Somewhere between 80 and 120 degrees of anterior elevation and abduction seems to be what's achieved with either type of shoulder replacement, and then to a lesser degree, they're going to have their internal, external range of motion. It's not a set value. From the studies that I read, it seemed to be that they just had a significant percentage improvement from what they started with, as opposed to when we think about our knee replacements, that architecturally that new prosthetic allows a certain amount of range of motion. The shoulder is more complex than that, so they really see it as an improvement from where that particular patient started. Generally speaking, 80 to 120 degrees of that flexion abduction achieved. Are there any numbers on the rate of shoulder replacement surgeries with no failures? You know, let me look back. I guess it would be the opposite of the rate that does have failure, and failure can occur, as we're seeing, for several different reasons. I think I have that number. I don't want to misspeak. Give me 1 second. I know what slide I want to look at to see if I wrote down the numbers. I don't have it written down there. So, question is, what's the data on the failure rate of the shoulder replacement? When we look at the medium-term data that they still have, it was in the 90s, the percent of survivorship of the prosthesis. So it looks like that it's probably around an under 10% failure rate that is occurring for the different procedures. It varies somewhat based on the research that you're looking at. Next question, at what time frame may internal rotation, reaching behind the back range of motion be initiated? You're always going to follow the physician protocol, because part of it depends on what additional procedures the patient had done and how well the physician thinks the components are aligned and how much time they need to heal. Generally speaking, the protocols that I was looking at, it seemed to be after the 2-month mark. But again, you really need to follow the physician protocol, and now you have more information to help you guide that conversation with them to understand why their protocol is as restrictive or as free as it is, and how it may not apply to all patients as only one standard. Okay, the question is, the use of pulleys seems to be on again, off again. Do we have more data about the effectiveness of using pulleys for shoulder rehab? I didn't specifically pull data on that question. However, many of the protocols did still include overhead pulleys as an activity that was incorporated into rehab for this population as, an active assisted type of motion. The key here is that you do need to be mindful of the shoulder position and avoid that precaution of not being too far into extension. And many of the protocols were saying to keep the patient in that scaption plane when they are utilizing it. I would also think that if it is being utilized with this population, an additional precaution to consider in terms of safe application is when the patient initially goes to grab that pulley, are they going back into that extended adducted position just to reach it? So I would say really be sure if you are utilizing it with this population, can they maintain their precautions and contraindications with movement when they're utilizing the pulley. If not, it may not be the best choice for that particular patient. Okay, so can you tell me the theory behind progressing the submaximal isometrics? Generally speaking, with submaximal isometrics, the idea is that there is no joint movement occurring. So you're changing the forces that are being created across the joint while still enabling contraction of the muscle to avoid atrophy and maintain that kind of motor learning and recruitment. So when we look at the patient with shoulder arthroplasty, which muscles you're able to utilize, whether they're shoulder muscles that would create forces across the glenohumeral joint, that will be put off a little further versus scapular muscles like the rhomboids. We can do isometrics earlier because that's not altering that compressive and shear force across the glenohumeral joint that was altered. Okay, so the question is, why do we want to maintain the shoulder in slight abduction after surgery? The abduction positioning they might actually have in their sling, that little wedge, tends to be more with the reverse shoulder arthroplasty, and that's because they're trying to maintain appropriate alignment of that glenohumeral joint that has been reversed and just give a more appropriate aligned length tension relationship for that biceps, or sometimes the physician has actually tried to repair some of the rotator cuff if that was possible to see if they can retain any of it. So we don't want to stress the positioning of that repair. It is something though where you want to find out from the physician what additional procedures he may have done along with just the replacement, and that might give you some more insight as to what tissues they're trying to avoid stressing while they heal.